Hello, my name is Samreen. Can I know your name, please?
My name is Yasin.
Do you have any pain in your body?
No.
So today I am going to examine your musculoskeletal system.
Okay.
Inspect the shoulder and shoulder girdle anteriorly, then capsule and related muscles posteriorly. Note any swelling, deformity, muscle atrophy, or fasciculation. Look for swellings of the joint capsule anteriorly or the bulge in the subacromial bursa under the deltoid muscle. Survey the entire upper extremity for color changes and skin alterations or unusual bony counters. Now, palpation begins by palpating the bony counters and structures of the shoulder, then palpate any area of pain. Begin medially at the sternoclavicular joint, then from behind palpate the acromion, then coracoid process, great tuberculous, bicipital groove, and tendon, and at last subacromial subdeltoid bursa. Now we will examine the range of motions. First, flexation, where patient raises his arm in the front and overhead. Extension, where he moves his arm behind. Abduction, raising his arm out to side and overhead. Adduction, crossing an arm in front of his body. Internal rotation, placing a hand behind his back to touch his shoulder blade. External rotation, rotating an arm towards the ceiling from the shoulder level. Adduct the patient arm across the chest. Ask the patient to touch the scapula using jaw motion. First, abduction, external rotation, and adduction and internal rotation. Press on the scapula to prevent scapular motion with one hand and raise the patient's arm with the other. This compresses a greater tuberosity with the humerus against the acromion. Flex the patient's shoulder and elbow to 90 degrees with the palm facing down, and then one hand on the forearm and one on the arm. Rotate the arm internally. This compresses the tuberosity against the supraspinatus tendon and coracoacromial ligament. Ask the patient to fully abduct the arm to the shoulder level up to 90 degrees and lower it slowly. Note that abduction above the shoulder level from 90 to 120 reflects the action of deltoid muscle. Elevate the arm to 90 degrees and internally rotate the arm with the thumb pointing down as if emptying a can. Ask the patient to resist as you are placed downward pressure on the arm. Inspect the position of the hand in the motion for smooth natural movement. When the fingers are relaxed, they should be slightly flexed. The fingernails edges should be in parallel. Inspect palmar and dorsal surface of the wrist and hand carefully for swelling on the joint or sign of trauma. Observe the contour of the palm, namely thinner and hypothinner reminiscences. For palpation, palpate the wrist joint, palpate radial styloid bone and anatomical snuff box. Note any swelling or bogginess or tenderness. Palpate the metacarpal phalangeal joint. Compress the metacarpal phalangeal joint by squeezing the hand from each side between the thumb and finger. Palpate medial and lateral aspect of the interphalangeal joint. Check for swelling or tenderness using the same technique. Examine the distal interphalangeal joint. Now we'll examine the wrist range of motion. First, for flexion, patient instruction should be palm down, point your fingers towards the floor. For extension, patient instruction should be with palm down, point your fingers towards the ceiling. For adduction, palms down, bring your fingers towards the midline. For abduction, palm down, bring your finger away from the midline. To test hand grip strength by asking patient to grasp your finger, which is second and third fingers. This test functions for wrist joint, the finger flexors and intrinsic muscles and joints of the hand. To test thumb function, ask the patient to grasp the thumb against the palm and then move the wrist towards the midline in the ulnar deviation. To test thumb abduction, ask the patient to raise the thumb straight up as you apply downward resistance. Test Tinel sign test by tapping slightly over the course of the median nerve in the carpal tunnel. To test failing sign test, ask the patient to hold the wrist in flexion for 60 seconds with the elbow fully extended. Alternatively, ask the patient to press back of both hands together to form right angle. This maneuver compresses the median. Inspect the gait for the smooth rhythmic flow of the patient enter the room. The knee should be extended at the heel strike and flexed at all other phases of swing. Inspect the knee, noting their alignment and any deformities. Note loss of the normal halos around the patella or atrophy of the quadricep muscles. Palpate the tibiofemoral joint. Face the knee of the patient. Place your thumb in the soft tissue depression on either side of patellar tendon. Identify the groove of the tibiofemoral joint. Note that the inferior pole of the patella lies at the tibiofemoral joint line. By pressing your thumb downwards, you can feel the edge of the tibia plateau. Follow it medially and laterally until you are stopped by the converging femur and tibia by moving your thumb upward toward the midline to the top of the patella. You can follow the articulating surface of the femur and identify the margin of the joint. Press on the medial soft tissue depression along the upper edge of the tibial plateau with the tibia slightly internally rotated. Place the knee in slight flexion and palpate the lateral meniscus along the lateral joint line. To palpate medial compartment, move your thumb upward to palpate the medial femoral condyle. The adductor tubercle is posterior to the medial femoral condyle. Move your thumb downward to palpate the medial tibial plateau. Also, medially palpate along the joint line and identify the MCL. Also, on the lateral surface, ask the patient to cross one leg so that the ankle rests on the opposite knee and find the LCL. Palpate patellofemoral compartment, locate patella and trace patella tendon distally until you palpate the tibial tuberosity. Start 10 cm above the superior border of the patella, well above the pouch, and feel the soft tissue between your thumbs and finger. Move your hand distally in progressive steps, trying to identify the pouch. Continue your palpation along the side of the patella. Note any tenderness or increased warmth. For minor effusion with the knee extended, place the left hand above the knee and apply pressure on the suprapatellar pouch, displacing or milking fluid downward. Stroke downward on the medial aspect of the knee and apply pressure to force fluid into the lateral area. Tap the knee just behind the lateral margins of the patella with the right hand. Balloon sign. Place the thumb and index finger of your right hand on each side of the patella. With the left hand, compress the suprapetular pouch against the femur. Palpate the fluid ejected or ballooning into the space next to the patella under the right thumb and index finger. Balloting the patella. To assess larger effusion, you can also compress the suprapetular pouch and ballot or push the patella sharply against the femur. Watch the fluid returning to the suprapetular pouch. Palpate the gastrocnemius and soleus muscle on the posterior lower leg. Their common tendon, Achilles, is palpable from about the lower third of the calf to its insertion on the calcaneus. To assess knee range of motion, begin with flexation. Ask the patient to bend or flex knee. Extension, straighten your leg. And for internal rotation, ask the patient to swing your leg towards the midline. And for external rotation, ask the patient to swing leg away from the midline. McMurray test. With the patient supine, grasp the heel and flex the knee. Cup your other hand over the knee joint with the fingers and thumb along the medial joint line. From the heel, externally rotate the lower leg. Then push on the lateral side to apply a valgus stress on the medial side of the joint. At the same time, slowly extend the lower leg in the external rotation. The same maneuver with the internal rotation of the foot stresses the lateral meniscus. Abduction stress test. With the patient supine and the knee slightly flexed, move the thigh about 30 degrees laterally to the side of the table. Place one hand against the lateral knee to stabilize the femur and the other hand around the medial ankle. Push the medially against the knee and pull laterally at the angle to open the knee joint on the medial side. Adduction stress test. With the thigh and knee in the same position, change your position so that you can place one hand against the medial surface of the knee and the other around the lateral ankle. Push the laterally against the knee and pull medially at the ankle to open the knee joint on the lateral side. Anterior drawn sign. With the patient supine, hips flexed and knees flexed to 90 degrees and the feet flat on the table, cup your hand around the knee with the thumbs on the medial and lateral joint line and the fingers on the medial and lateral insertions of the hamstrings. Draw the tibia forward and observe if it slides forward like a drawer from the under the femur. Compare the degree of forward movement with that of the opposite knee. Place the knee 15 degrees of the flexation and external rotation. Grasp the distal femur on the lateral side with one hand and the proximal tibia on the medial side with the other. With the thumb of the tibial hand on the joint line, simultaneously pull the tibial forward and femur back. Estimate the degree of the forward excursion. Position the patient and place your hand in the position describing the anterior draw test. Push the tibia posteriorly and observe the degree of backward movement in the femur.